Ladies and gentlemen, thank you for joining us for this important webinar introducing the new Accountable Care Collaborative Medicare-Medicaid program. Today, providers will learn more about the new ACC Medicare-Medicaid program and how it will help Medicare and Medicaid work together better for patients. The ACC Medicare-Medicaid program began in September and will help to enhance care coordination for full benefit Medicare and Medicaid patients. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time on the phone, please press *0. As a reminder, this conference is being recorded Tuesday, October 28, 2014. I would now like to turn the conference over to Van Wilson, ACC MMP Project Manager. Please go ahead.
Hi, and good afternoon, everybody. We're excited to have so many people on the line here today. We've got around 300 or so on the web, and just as many on the phone line here. I'd like to introduce you to our presenters today. Elizabeth Baskett will be helping us out with some questions towards the end of our presentation today. I am Van Wilson, the Accountable Care Collaborative Medicare-Medicaid Project Manager, and then two of our colleagues here, Matt Vidal and Sophie Thomas, will be helping us out with the presentation as well. So we'll cover a number of topics today, all relating to the Accountable Care Collaborative Medicare-Medicaid program. It's a bit of a long name for our program, but if you hear it, we'll most likely refer to it as the ACC MMP. So we're going to look at what that is. We're going to look at why it's important and how it works here in the state of Colorado. I'm going to take a look at who's eligible and how patients enroll. And then finally, we'll look at how it improves care across the provider continuum. And then we'll leave you with some resources on where to get some more information about the program and for your clients. First, let me make a note about patient versus client versus member. There's a lot of discussion out there about what is the appropriate way to refer to those we serve. So for this webinar, we've used patient most of the time, but know that that's pretty interchangeable with client and member as well. I think the jury's still out on that one. All right. So in one slide here, in a tiny little nutshell, this is the Accountable Care Collaborative vision, is to transform Colorado's fee-for-service healthcare delivery system into a regional, outcome-focused, client and family-centered coordinated system of care. And so by enrolling clients into the Accountable Care Collaborative, we're able to transform their healthcare delivery system, essentially. So what is the ACC, or the Accountable Care Collaborative? So it began in 2011 and has quickly become Colorado Medicaid's primary delivery system for Medicaid. And so we have currently around 700,000 Coloradans that are in this system. It's what is referred to as a managed fee-for-service system, and it's made of 3 components, which I'll look at here in just a moment. But the ACC allows patients to get some more assistance navigating a very complex healthcare system. It also allows them to keep the physicians that they've been seeing and access all of their same benefits that they had previously in their fee-for-service delivery system. The ACC provides a degree of enhanced care coordination and helps clients get access to other types of long-term supports and services and social supports as well, or non-medical services. So here's the 3 major components of the Accountable Care Collaborative. So at the core are what we call regional care collaborative organizations. And you may have heard the word Rico out and about here in your work around the state. So there's 7 of these across the state, and I'll show you the map here in just a moment. But they really manage the primary care network and the specialty care network, as well as provide care coordination for all their members. Also, a big backbone of the program is the network of primary care providers. And so every client enrolled into the Accountable Care Collaborative is assigned a PCMP, or they can choose one. And then finally, our statewide data and analytics contractor, or the SDAC, as you may have heard it referred to. So this entity, they gather healthcare information and allow us to look at the quality of service that we're providing, the quality and volume of service, and allows us to pay in such a way that incentivizes quality. All right, this is one of our favorite little visual slides here of the ACC. You could substitute care coordination at the top there with the RICO, or the Regional Care Collaborative Organization. Their task is really to bring together a very disparate and fragmented world of providers of all types, from the community services level to the BHO and specialty care level, and then acute care on the hospital, and ambulatory and outpatient services on that side. So they've got a big task, but they're attempting to coordinate this service and supported on the foundation that is the data and analytics from the SDAC. So how does the ACC help patients or clients or members? So our RICOs, a good way to think about them is in terms of integrators. They've really become the integrator in the Medicare delivery system. And so in a sense, they're establishing these partnerships and improving communication across the continuum of care. Serving the Medicaid population is not simple, and so they're really trying to push forward the person-centered care. And then finally, the ACC, or the RICOs, connects individual clients with the networks of primary care physicians, direct service providers, and social supports of all types. So how does the ACC help providers? And this perhaps may be the question that is first and foremost on your mind, this being a webinar for providers. So in a nutshell here, the ACC established these 7 regional care collaborative organizations, or RICOs. And that's it's a large added value to providers all across the state, because they can help address gaps in care for our patients, for our clients. And again, in a nutshell, it gives you an added resource that you can reach out to when you have difficult or high-utilizing clients and patients, so you can help connect them to the appropriate resources that may be driving their health more so than any type of acute or primary care. So refer your patients to the RICOs, and a few examples of this. Let's say you're a primary care doctor. A client comes in hungry to your office, and it's because they're on a wait list for Meals on Wheels. You can't do much about that in the office unless you provide some degree of care coordination yourself. And so that in that instance, you could give your RICO a call, connect the client with their care coordinator, and get them the food that they so desperately need. Let's say you're a behavioral health provider, and your client's just been kicked out of their home. Well, they're obviously not going to get very healthy if they don't have a roof over their head. And so this would be an avenue by which you could support your client through the RICO. Okay. So again, ACC and the RICOs are here to help. If you need anything for your clients, for your patients, ask the RICOs. Again, they're providing that additional support through care management, care coordination rather, and medical management. Additionally, if you're on the kind of community side or home and community-based services side, they can help you, help your clients rather, manage their health, manage their acute health by assisting with follow-ups. They can check in on them, help track appointments, and then help your clients fill prescriptions. So they're really the link between your client and the services and specialists that exist out there. So in this next slide here, this is a map of the regional areas for our regional care collaborative organizations. So take a moment here and identify which RICO region you are in. So note your county, and then look down there at the key and find your region. And then here on the next slide is your contact information for that RICO if you don't already have a relationship built with them already. A lot of what they're going to be doing in this program over the next couple years is reaching out to the full continuum of providers across the state of Colorado and attempt to standardize some of the communications across that. And I'll get into that here in just a moment. Okay, so that's the ACC. To give you a little bit of context around the background of the program, the federal government kind of saw a pretty big rise in the expenditures for individuals who have both Medicare and Medicaid. And you'll note the acronym here, MMEs. And so they approached states and made some money available to test out different strategies to integrate services for people who have both Medicare and Medicaid. So Colorado pursued that funding and received it, and then enrolled clients in this program September 1st. So you'll notice here that circle with the 32,000 Medicare-Medicaid enrollees. Prior to this program, they were just existing in what I like to call fee-for-service land. So with this new program, we're taking those 32,000 individuals, keeping their benefits the same, allowing them to keep the same doctors, but we're enrolling them into the Accountable Care Collaborative. And so they have access to all of these added benefits through the Rico. So care coordination, medical management, connection to a primary care medical provider, and all of that. So in 2 or 3 slides there, you can see that's essentially the makeup of the program. All right, let's take a quick look at who are our MMEs, or our Medicare-Medicaid enrollees. So I could spend a long time talking about the demographics and the statistics on this population. It's a wide variety of individuals, all ages. About 50% are under the age of 65. About 50% are over the age of 65. Slightly more women than men, and you can kind of account for that by the longer lifespan or life expectancy for women in older age. These 5 bullets here don't really do enough to help you understand this population because they are so varied. But in general, they need a higher degree of support. They're a small proportion of our Medicare and Medicaid population, but they account for a pretty large proportion of the spending, around 40%, and they make up around 15% of the population. Which goes without saying, they rely almost entirely on government programs for their health care. If they're receiving the full Medicare and Medicaid packages of services, that's pretty much all they have. So if you can take a moment and think about the pathways by which people get onto Medicare and Medicaid, it won't take you long to conclude that most of them have low incomes and are vulnerable and have a great need of a few resources. So a little bit more on who is eligible, the kind of technical side of that. Again, these are clients who have full benefit Medicare and Medicaid benefits, packages of services. So have Medicare Parts A and B and currently be in the fee-for-service delivery system and eligible for Part D, have the full package of Medicaid benefits. And then finally, note that we're not enrolling anybody who is already in a private or a public health insurance program or a managed care program. So that's people enrolled in Denver Health, Medicaid managed care, Rocky Mountain Health plans on the Western Slope, any of the Medicare Advantage plans across the state, or PACE enrolled individuals as well. So all of those individuals will be excluded from enrollment, which leaves us with around about 32,000 Coloradans that are currently receiving services in a fee-for-service environment. So that's who we're after with this program. So let's look at how enrollment works. As I noted, when we first began here, we enrolled our first clients into the program, our first cohort, September 1. And we're going to be continuing that monthly rolling enrollment until March. So enrolling relatively small groups of individuals. So in September, we enrolled around 7,500. October was around 7,000. No enrollment for November, and we've got a little slide on this next here that we'll show you. And then from December on out, we'll be enrolling around 4,400 individuals across the state. And so that'll be somewhat evenly distributed amongst the Rico regions. So it's a passive enrollment process. clients receive a notice that we have a slide here in just a moment. They'll receive a notice 30 days before enrollment or effective date. So at that time, patients can opt out of the program. They can opt out after they're enrolled or disenroll for any reason at any time. And that was a big patient protection that CMS required of us for the program. And again, only patients may opt out of the program. And providers, we really discourage and prohibit them from encouraging patients to opt out of the program. So as I mentioned, it's a phased-in approach over 7 months. And we're really relying on the foundation of the Accountable Care Collaborative and our Rico and Primary Care Network to kind of optimize as we begin phasing in individuals. So we're also enrolling based on acuity, enrolling those who are the least acute first, moving on to those who require higher degrees of care, ending in individuals who are in a nursing facility. And you can see that reflected here on our enrollment schedule. You'll also notice that we're enrolling clients first who have a primary care provider that's contracted with the ACC, and then enrolling clients who have a primary care provider that's not contracted with the PC or with the ACC second. So I'll just make a little plug in there. If you know that you're a Medicaid and Medicare provider and you're serving dual eligible clients, there's money out there for you to be had if you enroll into the ACC and begin providing services through that arrangement. On the next slide here, you'll take a quick look at our patient enrollment materials. So this is just the very front page of a 12 or 14-day packet, or page packet rather, that clients are receiving. It includes most of the details of the program, all sorts of contact information, grievances and appeals information, how to choose a primary care provider. This is just the one piece of enrollment material that you're seeing here. We've got a whole packet, and that's available on our website, which the URL I think will come here at the end of our presentation. Okay. So what happens when a patient or a client enrolls into this program? So first and foremost, we want to make this absolutely crystal clear that their Medicare and Medicaid benefits remain exactly the same. We're not changing anything in the delivery system when it comes to that. So if a client is currently receiving long-term supports and services and you're providing that to a client, continue doing that. Continue submitting your claims and reimbursements exactly the same. That's not changing. Even more important, patients can remain with their physician that they have seen and that they're comfortable with. They do not have to change doctors. We're not forcing them to choose a specific network of doctors that are contracted with the ACC. They can remain enrolled or remain seeing that primary care provider regardless of their relationship with Medicaid and the ACC. Last point there, the RICOs will contact the client to offer additional supports and a service coordination plan after they enroll. And so we'll get into the details of the service coordination plan and that outreach effort here in our next component of our presentation. And I'll go ahead and hand the microphone over to my colleague, Matt Vidal, and he's going to talk a little bit about the program components.
Okay, thank you, Van. Van talked a bit about the ACC, gave a background and a program overview, talking about eligibility and enrollment. I'm going to spend some time today talking about some of the important elements of the program and how they will hopefully make the program successful. So there are a few strategies that have been developed from the planning and implementation process that will help for the patients to improve their health outcomes as well as enhancing the care coordination that they receive. So these elements are the service coordination plan, or the SCIP as we refer to it. There are cross-provider communication agreements, protocols, which exist between the RICOs and various organizations that serve these patients. And then there's an appeals and grievance alignment process as well. So I'm going to start by talking a bit about the service coordination plan. So when Colorado reached an agreement with CMS to go forward with this program, there were care coordination requirements that were outlined in the agreement, and every state doing one of these programs has to adhere to these requirements. And one of these requirements is for a plan of care for every individual to take place. And so in Colorado, our plan of care is called the Service Coordination Plan. And it is a document that basically acts as a snapshot to everything that's going on with the client at that time. And so the Rico is responsible for essentially reaching out to every patient, and they can choose or delegate who is responsible for completion of the service coordination plan. But then that delegate will reach out to every patient and make sure that a skip is completed for each one. And so the skip is a document that includes everything that's going on, and it's the blueprint for a patient meeting their goals and improving their health outcomes as well. So it can list the providers that they are seeing, medications that they're using, services they receive. So it's really a way to outline everything that's going on with the patient at that time. But there's also a section for the patient to be involved in that, and they can include their short and long-term goals as well. So in essence, a really effective service coordination plan will help to identify any gaps in care that exist, as well as potentially any duplicative services that are going on for the patient at that time. So during the planning and development process of this program, there was a very robust collaborative process for creating the skip. And the department was involved with the RICOs in this process, and a work group was formed with the idea of a lot of input and collaboration to really to make the most out of this document. And so the RICOs actually had an opportunity to test the skip and bring it to some of their patients and some of their clients just to see how it was working and bring some of that feedback back to the group. So there was a very long and collaborative process that went into this document, so it's a very important element to the program. And this so the next slide here talks a bit about how the skip works with other care plans. We recognize that there are probably other assessments and care plans that exist for patients, and so the skip is not meant to supersede or duplicate that. It's meant to work with these plans and complement them. The basic idea is to identify any gaps and give a blueprint for the RICO care coordinator to delegate how these gaps can be fulfilled and work with the providers among the continuum. So how can RICOs help with this? So each patient is different and they have different needs. And so when the RICO delegates care coordination to a care coordinator, it is the responsibility of this care coordinator to reach out to the patient to determine what their goals are and how they can reach them. They will also work with the patient to address any barriers to the care and services that they require. So the RICOs will reach out to any primary or specialty behavioral health care providers and check in on appointments, any housing needs, transportation needs. Van spent some time talking about some examples of some of areas where the RICOs can assist. And so the service coordination plan will, I guess, outline where the needs are and how the RICO care coordinator can address them. So that was just a real brief background of the service coordination plan. The second element of the program are cross-provider communication agreement protocols. And one of the main elements for the protocols is identifying clients that may exist amongst various or numerous providers. So this slide here shows from the planning process for planning for the program how the RICOs came about developing these communication agreements. So they worked with various organizations such as single entry points, community center boards, home health agencies, hospitals, skilled nursing facilities, hospice agencies, behavioral health organizations, and disability organizations. Basically all the networks that where there may be or communication may be lagging, or there may be clients who see various providers, in order to prevent duplication as well as strengthen relationships among the continuum of providers. So the protocols describe the process for identifying and working with patients and fulfilling existing responsibilities, as well as improving the contact and communication amongst providers. So when the RICO delegates a care coordinator to fill out a service coordination plan, the RICO will also reach out to providers along this continuum to see if there are any gaps in the services that the client is receiving, or if there are providers who have a shared client, how they can improve communication and enhance the care coordination for that client. So this is one of our little visuals that we've included in many of our training PowerPoints that describes the linkages that are being formed with the service coordination plan as well as the protocols. So when the care coordination is enhanced and when a really good service coordination plan is filled out, then the care coordinator, the patient, and any providers that the patient is seeing will all be working together and communicating with each other to know what health outcomes a patient is trying to achieve and what services that a client receives. So for the service coordination plan, it's important to coordinate who is actually doing the case management. As mentioned, there may already be care plans or assessments in place. A patient may already have a case manager, and that's great. The service coordination plan isn't here to duplicate anything or supersede any assessments that already exist. But it's really important to identify who is the best person to coordinate care for these patients. So the RICO delegates who will be responsible from their side to fulfill care coordination, but it's also important to work with other case managers to have continuous updates on the progress of the patient. If there's any changes in status for that patient, it's important that this is noted and updates to both the service coordination plan and regular communication amongst providers be upheld. So it's another important part for the service coordination plan is really for the patient to be involved in this. And so rather than just a care coordinator filling out a skip and then giving it back to the RICO, the skip really promotes patient activation and being involved in the healthcare team. So there's an area for them to fill out their goals and what they would like to achieve. And then it's the responsibility of the delegated care coordinator to make sure that the skip is updated regularly and maintain regular communication amongst any providers as well as the RICO. So I'm going to turn it over now to my colleague, Sophie Thomas, who's going to talk a bit about the appeals and grievances process as well as some other nuts and bolts about the program.
All right, thanks, Matt, and thanks everyone for joining us today. That was a great introduction to the service coordination plan and our communication protocols. And I'd like to point out that we do have more comprehensive trainings on all of these components of the program. They're located on our website, which I'll show you in just a moment. So an important part of this program has been to align the appeals and grievance processes for the Medicare and Medicaid programs. Early on in the planning phases, an alliance of all the organizations that assist Medicare and Medicaid clients with appeals and grievances was formed. And this alliance has played a key role in providing clients with accurate information on who to contact for what issue. And we are now actually in the process of taking this a little bit further and creating a single statewide ombudsman program for our Medicare-Medicaid enrollees. This ombudsman program will serve as a single point of contact for all patient questions, concerns, complaints, and appeals that are related to both their Medicare and their Medicaid benefits and services. This Ombudsman program is the result of a partnership with our sister agency, the Department of Human Services, as well as the Legal Center, who serves as our current long-term care ombudsman. And we are still early on in the planning phases for this program, but we will certainly keep you updated with any developments that are coming. Okay, so we're going to switch gears here and talk, these are the last couple of topics we're going to cover before we open up the line for your questions this afternoon. We're going to look at quality metrics, quickly claims and reimbursement, program resources, and I'll talk about the regional conferences that the RICOs have been hosting. So in order to monitor success for the program, we have about 16 quality metrics, and I'll cover just a few of them in a moment. We're also planning an early indicators report that will measure client perceptions and satisfaction in the early phases of this program. And also CMS will be conducting an independent evaluation as well. So here are some of our quality measures. These aren't all of them, but the ones that we thought would be most pertinent to our provider audience today. They're broken down into two buckets. We've got our core quality measures and then our state-specific quality measures. And if you look at the core quality measures, these are really just national standards to improve the overall healthcare system. So we're looking to see a reduction in hospital readmissions. We're looking at acute care admissions that could have been prevented by outpatient or ambulatory services. We're looking for follow-up after hospitalization for mental illness. We're looking to improve care transition record transmission, depression screening and follow-up care, and screening for fall risk. And then this last bucket here, our state-specific process measures, are specific to Colorado's demonstration program, and we will be looking at the number of completed skips within a certain time frame. We're looking at PCMP training on disability and cultural competence provided by the RICOs, and we're also looking at a 30-day follow-up after hospital discharge. So here's a slide on claims and reimbursement, and the message here is real simple. The process remains the same. Providers will continue to submit fee-for-service claims, and for RICOs and PCMPs, they do receive a per-member, per-month payment for their Medicare-Medicaid patients, and these payments go to support coordinated care for patients. And RICOs can delegate their care coordination to the PCMPs and also pass their payment along to the PCMPs as well. So we've already shown you this slide, but we just would like to reiterate the message that the ACC and RICOs are here to help. If you need anything for your patient, connect with your RICO because they can provide added support, practice support through care coordination and medical management. They link your patients to services and specialists, and through participating in the Accountable Care Collaborative, your patients will get greater care coordination. These next couple of slides are program resources. This first one is for providers. The Healthcare Policy and Financing Department has recently redone its website, and we've broken down into 3 different buckets, one for clients, one for providers, and one for stakeholders. So if you're looking for the provider training pages, just follow the links from the provider tab, and you'll click to expand the Accountable Care Collaborative Medicare-Medicaid program. And on our website, we have a whole toolkit for providers. We have the other webinars that we've hosted, those recordings, including our introduction webinar and our SCIP training. We have copies of our communication protocols, client outreach materials, including enrollment letter and handbook, as well as our SCIP form and instructions on how to fill that out. For patients, we have a great deal of resources on our website. We have enrollment materials, including the enrollment letter, member handbook, a list of frequently asked questions, and RICO information. So if your patient has any questions regarding this program, we'd like you to direct them not only to their RICO, but to our website in hopes that we can answer some more of their questions. This slide here is a table. I'm sorry, it's a little hard to read, but it's a table that shows all the RICO regional conferences that have been going on around the state. The RICOs have been hosting these regional conferences, inviting various provider types to the table to talk about how they can all work together to help patients. And the ones that are grayed out, those are dates that have already occurred, but there are several more that are coming up. You see Region 1, Rocky Mountain, has one coming up in just a couple of days on October 30th, and Region 2 has one in Greeley on November 5th. And so if this interests you at all, we encourage you to contact your Rico and please join these conferences. They're very informative and a great way to build partnerships throughout the state. So again, we're going to just repeat, this is the Rico contact information slide. You can see locate your county on the right-hand side if you don't already know what Rico you're in. And if you have any other questions, we encourage you to contact your Rico and start working together with them. So that concludes our presentation for today on the Accountable Care Collaborative Medicare-Medicaid program. I see that we've been answering some questions in the chat box, but we now would like to open up the line to take any audio questions, and we'll also continue to answer any other questions you have.
And ladies and gentlemen on the phone lines, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and would like to withdraw your registration, please press the 1 followed by the 3. As well, if you would like to ask a question using the chat, it is located in the lower left corner of your screen. One moment please for the first audio question. And there are no questions on the phone lines at this time. I will turn the presentation back over to you.
Thanks. We've got a number of questions coming in through the chat log here, and I've been responding to some in line. I think one that I'll talk about right off the bat, there's about half of our clients, around half of that 32,000 number there that you saw, are on some sort of a Medicaid waiver program. The lion's share being on the elderly, blind, and disabled Medicaid waiver, who are already served by single entry points or SEPs. We've got a much smaller number of dual eligible or Medicare-Medicaid individuals enrolled in waivers that are managed by community-centered boards or CCBs. And so this is it's a delicate balance. The RICOs, we're currently asking them to reach out to those service providers, to those SEPs and CCBs first, before reaching out to their client. We want to leverage the expertise that is already existing out there. So if a single entry point or if a community-centered board is already providing a degree of care coordination for their client, the RICO really won't have a very big role to play. So we mentioned those communication protocols and agreements there. This is exactly the work that's going to be being done over the next couple of years with this program. It's really defining boundaries, defining roles and responsibilities around who needs to take care of these specific clients with care coordination. Anybody on the line yet, operator?
No questions on the phone lines at this time. However, ladies and gentlemen, as a reminder, to register for an audio question, please press the 1 followed by the 4. Thank you.
Thanks. Just give us a moment here. We're scrolling through quite a few questions. Going to see if any rose to the top here as more important. One moment. Yeah, so there's one question here about Medicare Advantage clients. Just want to reiterate that anybody currently enrolled in Medicare Advantage plan will be excluded from enrollment. We do know that because these systems and enrollment systems are large, extremely large, and there's some communication that takes months in terms of eligibility and enrollment. And so we receive a monthly file from CMS that has everybody enrolled in the Medicare Advantage plan in the state of Colorado, and we exclude anybody on that list from enrollment. That's not to say that there may be some churn in that population, as you may know. Clients do enroll and disenroll, sometimes very, very often. So it may be the case that there's a very small number of Medicare Advantage recipients that have been enrolled, but do know that we made every effort to exclude those individuals. so many questions. Just need to know which one to answer here. So our ombudsman process here is actually, it's very interesting and it's pretty exciting. So because this program really attempts to address the full spectrum of services, being Medicare and Medicaid, we wanted to do our best to align those appeals and grievances process. So the state received a grant, as Sophie said, to pursue a single statewide ombudsman that will be housed in the legal center. And so that work is brand new, and within 6 months' time, we should have a single statewide ombudsman that clients can call. For the time being, we're using existing appeals and grievances pathways for clients, and so that is Maximus. That is the MMCO, as they're called, the Medicaid Managed Care Organization Ombudsman. Oh man, I screwed that one way up. Medicaid Managed Care Ombudsman, or the Ombudsman for Medicaid Managed Care, as well as the Long-Term Care Ombudsman that is currently within the legal center as well. So those will be the existing pathways. There's a couple questions here about how to know if your client is enrolled in the program or with a Rico or with your PCMP. So if you are a primary care provider and you ping our system to determine a client's eligibility, that eligibility response will give you all the information that you need about whether or not the client's enrolled in the ACC, whether or not they also have Medicare, or enrolled and attributed to a Rico, or the Regional Care Collaborative Organization. So that's the primary pathway to identify clients. Outside of the primary care world, those providers that have access to the provider portal, as it's called, you'd really need to work closely with our Rico. And I think this is, the difficulty in this process is indicative of the fragmentation in the system. And so we really intend and hope for the Ricos to become an integrator or an informer in this program. And so when clients do begin seeing services with you, you're able to identify when that client is receiving services from you and providers X, Y, and Z. And so that's really, again, the work that's going to be completed over the next couple of years in improving and standardizing a lot of those processes that just don't exist currently. Let's see here. So there's a couple questions. We've got some providers on here, some social workers. Shout out to the MSWs in the crowd, about whether or not they need to enroll in the ACC. So currently, right now, the only contractual relationships that exist with Ricos or with the ACC is the primary care provider network. Right now, we're not pursuing any sort of formal contracting relationships with any other providers across the continuum. So those relationships will be a little bit more informal. If, let's say, you're an LPC or a social worker or something like that out in the field, your relationship with your Rico will be a little bit more informal, unless and some have gone down this way to enter into MOUs or a memorandum of understanding regarding those standard practices that I discussed a moment ago. Let's see here. So there's a question here about whether or not the independent plans, such as Denver Health or Kaiser, be mandated to provide the same coordinated services within their system. That will only be the case if those systems are a delegate of the Rico. So if I know here in our region, Region 6 contracts with Kaiser to provide some of these services. So in that sort of delegated relationship, we would absolutely expect Kaiser to provide and fill out a service coordination plan and use that as the tool for coordination just for those MME enrolled clients, for no one else. So I'm getting a couple other questions here. Well, I spoke to this a little bit about how SEPs will relate to the Ricos. and who has a final oversight of clients. Again, these are processes that don't yet exist. And so that communication agreements, those protocols, that's the work that's going to be done over the next few years here to really define that. When do we say a care coordinator is the lead care coordinator? Is it when a client is most comfortable? Is it what the client says, or is it what the state says, or is it what the RICO says? This will all be figuring it out here over the next couple years as we attempt to integrate this the continuum of providers. So a little bit more on that too. We were just discussing here in the room. In practice, a RICO care coordinator will be reaching out to that SEP or that CCB or to that entity that's already providing care coordination services. So we're asking you to come to the table at the very least and discuss care coordinator to care coordinator, the issues that you may be having with that client, or just discuss the client and potential gaps in care. But that's really where the lines and the roles and responsibilities will be determined in that kind of case-by-case, organization-to-organization level. So a good question here from Todd Leslie. Many of the quality measures appear to be related to timely hospital and facility follow-up. For example, the 30-day hospital readmissions. How will we complete timely follow-up without a system-wide real-time notification system? Todd, I wish I could blink my eyes and that would be the case. It is the case, however, that RICOs have, it's different across the state, but have made pretty significant inroads with hospitals to get those real-time notifications of discharge, of admission. And so, again, I'll keep reiterating on this. A lot of this work is yet to be done. And so that's what we're asking the RICOs to do over the next few years, is to create those relationships that allow that to happen. So a good question here from a former HCPUF colleague, Tiffany Rathbun, who will be permitted to speak with RICOs on behalf of the client, specifically, or if they are through a CCB or a community centered board, will it only be the case manager who can speak with the RICO? I think I understand the question there. So those case manager to case manager relationships will depend on a couple of different privacy and security questions that come up. But if those protections are in place, and if those agreements are in place, as long as what you're discussing relates to treatment, the TPO, treatment, that's the P, and operations, then it's fine. And so you would be discussing those sorts of client-related topics there. I'm not sure if I did the best in answering your question there, Tiffany. It disappeared on me as these other ones popped up. Yeah. And again, if you have any other questions about the, what's the right word, whether or not it's appropriate or whether or not it's legal to share information with your RICOs, contact your RICO. Discuss with them your concerns. These are federal and federal, HIPAA is a federal statute and federal regulation, and so that's enforced on that side, and it requires every organization to have their own interpretation of it. So contact your RICO if you have questions about that as well. So there's a question here at the end. Joyce Schmidt asks, how does this really impact residents in a skilled nursing facility? We're already a provider. Are we required to prepare this service coordination plan for the RICO? Only if you are a delegated entity and the RICO approaches you and asks you to do this. That may be the case, and in which case could potentially set up some sort of arrangement in that. Clients that are already in a nursing facility present an interesting dilemma for us because they're already receiving such good wraparound services that they really don't need much assistance from the RICO. But we are asking the RICO to reach out and identify these clients and at least make an initial effort to check and see that everything's okay. Quick question from Rick Salters. How do we find out who is part of the primary care provider network? And so you can go on our website and we can provide some links to that, although I think it's on our next slide here or the slide before. Maybe we'll send those in a follow-up email. You can find all of our provider lists there on our Medicaid website, and it'll tell you or not if they're contracted with the ACC. The easiest way to do that is to call Health Colorado or Maximus, our enrollment broker, and ask them. They can help clients get connected with the PCMP and have a list of all the providers that are contracted or not. Really interesting question here from Vernon Tryon. Sorry if I butchered your name there. Will RICOs have access to the SEP system or the bus? It's been a resounding no on this side, at least in the near future. We would love for that to happen. Right now, it's really HIPAA regulations that are prohibiting us from doing that. Unless a client is enrolled with a RICO, and it is reflected that way in our system, the state can share no information with them whatsoever about that client. That would be very inappropriate. We'd have no reason to. So until we figure a way around that hurdle, the bus will be specifically for long-term care and long-term supports and services. So Tiffany asks another question here. Do we need specific permission from clients and families to collaborate with RICOs? Not if your organization has an agreement with your RICO to begin with. And again, that speaks to the TPO and the minimum necessary information there. So if what you're discussing with your RICO is in regards to that, to taking care of their client, you're A-OK. You, again, reach out to your RICO to see what type of agreement you would need in place. Some are pursuing different options. Some are entering into MOUs with every organization in their catchment area. Others are leaning on that treatment. I can't remember the P, prescription, and yeah, the TPO requirement there. So there's a question about if the RICOs will have expanding or evolving key performance indicators. The measurement issue is an interesting one here, and we're dealing with it firsthand with this program. We won't, once the quality metrics are set for the program, they'll be set for the 3-year period that the program is running. In the full ACC, when you take a step back from just our program, those quality metrics it's a very long, arduous process, unfortunately, and so those are always looking at evolving, but not necessarily expanding at any time in the near future. Got a few minutes left here. That was the last question that I answered there was the last one that rolled through on the chat. So let me scroll back up and see if I can find any more important ones if I don't see any others come through.
Pardon the interruption. We do have a few questions on the phone line. Would you like to take those at this time?
Let's do that.
Perfect. So our first question comes from the line of Susan Langley. Please go ahead.
Hi, I'm Susan Langley. I work for the Denver Hospice and Optio Health Services. And I was wondering, are those SCIP, the written care plan, will all providers get to see that so they know who's caring for the patient?
That's a great question, and it's different depending on where you're at. So some RICOs have opted to use a little bit more IT infrastructure to be able to share the service coordination plan across the entire provider continuum. And so they'll have a provider portal that you can get access to and view it there. Others are still on a paper-based model, and so it presents its own challenges when you're trying to share the service coordination plan. But information is useless and obsolete if it's just sitting in a drawer. So we really intend for this, paper or not, to be shared across the provider continuum when clients are shared between providers. So that is definitely the intention. In fact, we've had some interesting discussions here about having clients own that plan, own their own plans. They show up in the physician's or in anybody's offices. They don't go out of the door until that provider reads their service coordination plan and helps them set up some strategies to reach their goals even more quickly.
All right, and one more just quick question for me. I happen to be a patient navigator as part of my job, and so I was wondering, and that's kind of a new field that's becoming more known in Colorado, and how does that position kind of fit in? Is that a position that's acknowledged or accepted as to being one of the providers for a patient?
I think what we know here at the Medicaid level is that people do better when they have more supports around them. And so the patient navigator, and what we've known through studies and through anecdotal work, is that the patient navigator role is an extremely important role and can help clients understand their situation. When it comes to the technical side of things, I think there may be some RICOs that have peer support specialists, or I'm trying to think of what else they're calling them, community health workers, a wide variety of different skill levels. And so they're ensuring that service coordination plan is initially filled out by whomever they delegate or whoever they choose. And then I would envision somebody like yourself as a kind of peer support specialist really working with that client. And I'm sure you're seeing them much more often than they would their primary care physician or even their care coordinator for that matter. So helping them stay on track with their goals, helping them identify any sort or helping them communicate with their care coordinator gaps in their care that they may be receiving and don't have the ability to communicate that as effectively as they may. Hope that answers your question.
It does, and I thank you very much for your time, and I think you did a really good job today with this presentation, so thank you.
Thanks. Good feedback. We appreciate that.
And we do have one more question on the phone line. It comes from Greg Eimerman. Please go ahead.
Yeah, the question I had is, as a provider for our folks who are dual eligible, will we need to receive any kind of authorization from the RICO in order to move forward with services, or is it just typical of what it's been in the past? We just provide the service without?
Good question. So as I noted earlier in the presentation, the claims and reimbursement system will be remaining exactly the same. So services that have traditionally required a prior authorization will continue to need a prior authorization, and we're not adding any additional requirements for services. So go and continue billing how you're billing. None of that will change.
Okay, great. Thanks.
Okay, I think that was our last question. We're a couple minutes over time here. We just want to thank you all for your time here today. You can see the email and my name and my phone number there on the last slide. Do feel free to reach out to us if you have any questions that keep coming up, or if you have clients that are enrolled and you have some questions about. Give us a call. Additionally, we'll be sending out a survey after this, as well as some additional information. We'd encourage you to complete that survey so we know how well we're doing and whether or not we're getting this message across. And that's all we have for you today. Again, we thank you for your time and all the best.
Ladies and gentlemen, that does conclude the presentation for today, and we do thank you for your participation.